Thank you very much. And I think it's a good problem to have when you can't figure out how to get to the front of the room. So first, thank you. When I was first asked to speak, I'm like, what do you want me to talk about? I'm not sure I know much about this, but from Catherine's introduction, the power of AI, I think what I'm going to talk about is where we're grounded in the people that we serve. And how do we use these tools, but stay grounded in the work that we do. And that's what I think OHTs do. So hopefully this is grounding for all of the great talks that we're going to have for the rest of the day. Ontario Health teams, that I consider to be a gift, as many of you have heard me talk, are the opportunity to truly be able to co-design an actual integrated health system that currently doesn't exist from the ground up. And this is the core of current health policy, at least in Ontario, but integrated care is heard around the world, and each country is trying to do it a little bit differently, but we can learn from each other. Centered on people in the community, surrounded by primary care, or health homes, as many of you here today have heard me talk about, seamlessly connect other partners who provide health and wellness services in neighborhoods with a purpose to keep people well in their homes where they wish to be. It gets complicated. The aim of healthcare evaluation and quality has evolved from 3 aims. Oh, there we go.
There you go. You can advance it with this thing here.
Perfect. Tech help is always helpful. The aims of healthcare equity, quality and evaluation have evolved from 3 aims to 4, and now 5, and is quickly moving to 6 as we think about the sustainability of our planet. People are more complex. Healthcare has made enormous leaps in disease management. Social determinants of health are recognized as essential to understand in terms of impact on health and wellness. Despite this, care is delivered in more and more silos. And now there are more navigators in our care teams than actual providers in some cases. There is more to understand that can be managed by one person, one patient, one family member, one provider, one organization, or I'll wager to say even one government. As we transform our healthcare system towards a fully integrated patient care system, artificial intelligence stands out as a game-changing enabler. It's not a magic bullet, but when used wisely, it can amplify the core aims of integrated care: access, coordination, prevention, and equity. Ontario health teams are uniquely positioned to harness this potential. Their mandate to organize care around patients and bring people together across the continuum makes them the ideal testbed and incubators for AI-enabled integration. We have much to gain. And as we learn to work collaboratively in OHTs, embracing AI to support this complexity, I believe is going to be key to our sustainability. A few examples to consider. AI as the nervous system of integrated care. Integrated care can be much like a living system. Primary care, hospitals, home care, mental health, and social supports are the organs. But AI can act as the nervous system, sensing, interpreting, and coordinating. Imagine AI algorithms that can identify high-risk patients before their crisis hits, or flag gaps in follow-up after hospital discharge, an emerge visit, or a surgical procedure. Imagine algorithms that can inform care planning based on real-time data, not what we hear about weeks or months often when a patient has finished part of their journey. For an example, risk prediction tools used by an OHT could help the local primary care teams proactively reach out to patients with complex chronic diseases or frailty. And rather than working in silos, OHT partners could use a shared intelligence layer powered by AI to target the resources where they will have the most impact. Different people need different things at different times. It's often too complex for one provider to sort out. Avoiding unnecessary emerge visits, facilitating hospital discharges, and preventing readmissions, this will keep people well in their homes where they want to be. Strengthening the attachment and access to primary care. OHTs, under the new Dr. Philpott mandate of the Primary Care Action Team, are all working hard to attach patients to primary care. In our OHT, I'm so excited to say we're on a path to attach every person to a person-centered health home by the end of March 2027. AI can be a critical force multiplier. Smart triage systems with integrated waitlist platforms can match unattached patients to available providers based on geography, need, and team capacity. AI-driven chatbots and virtual assistants could help patients navigate their OHT, book appointments, renew prescriptions, and connect to urgent or community-based services. Primary care providers, burdened by documentation, can benefit from AI transcription and summarization tools, freeing up time for actual direct patient care. In our OHT, we provided AI scribes to primary care providers to assist with the overwhelming administrative burden they currently work with. You'll hear more about this a bit later. But the attachment of thousands of people who need to be connected can be facilitated by AI triage systems, such that the most needy, who are often the least vocal, can access the care they need in a timely way. Transitions between hospital, primary care, social services are often where people fall through the cracks. AI can change that. Within an OHT, AI-driven coordination dashboards could pull real-time data from hospital records, community EMR, and social care systems. These dashboards can then alert the care coordinators when a patient is discharged from hospital and has no primary care follow-up, or when a home care referral is delayed. The addition of virtual care technologies to these dashboards can then flag when someone's health is not improving as expected and intervene earlier. Over time, predictive models can help OHTs shift from reactive to anticipatory care, deploying resources ahead of the acute episode. By embedding AI tools in their digital backbones, OHT can make integrated care real and visible, not just a vision, but a daily practice. AI also holds the power at a population health level. OHTs are expected to deliver care delivered to local needs, and AI can guide this work. Machine learning models can analyze patterns in emergency visits, hospitalizations, and chronic disease prevalence by neighborhood. AI can help identify equity gaps for existence where newcomers, Indigenous patients, or rural residents have poor outcomes and access. This would enable place-based planning, geographical neighborhoods, designing services that reflect real population needs, and focusing health home development in high-need zones. This brings geographic modeling to a whole new level and to truly match the needs and resources in an equitable manner that we're just not capable of doing on our own. Done right, all of this can support OHTs in delivering the localized, data-driven, and equitable care that they are designed to serve. Perhaps most importantly, AI allows us to build what OHTs were always intended to become, learning health systems. Every patient interaction creates data. AI can mine this data for trends, inefficiencies, or early warning systems of system strain. OHTs can feed this intelligence back into service design, funding allocation, and continuous quality improvement. This is the future of integrated care, a responsive, dynamic, self-improving system built on real-world evidence. But the promise of AI will not be fulfilled without intentional design. Change is hard, and the unknown invokes fear, which risks paralysis. OHTs must invest in data governance, privacy safeguards, and algorithm transparency. Clinicians and patients must be at the table to ensure the tools are usable, unbiased, and aligned with local care values. Equity must be central. If AI is trained on biased data or deployed without oversight, it can entrench the disparities rather than dismantle them. Fortunately, OHTs, rooted in, not that I'm biased or anything, rooted in their communities and composed of the diverse partners that we have, are perfectly positioned to co-design the AI tools that serve people, not just systems. In conclusion, I believe AI is not the goal, but it's the enabler. OHTs have already laid the groundwork for integrated, person-centered care. We have the people at the table to truly co-design an integrated, person-centered system. AI can amplify and accelerate this vision, connecting people to primary care, smoothing transitions, closing the equity gaps, and building a smarter, kinder, and more responsive health system. As we move forward, let's ensure our use of AI is governed by our values, guided by our communities, and focused on what matters most: better care, better outcomes, and better lives for the people we serve.